The Genuine Article. Discussion and commentary based on articles from JACC.
Hi, I'm Tony DeMaria, the editor of JACC, and I'm here with another issue of the Genuine Article. Now, one of the difficult things that physicians do on a daily basis is to balance risk and benefit. And I think this is often an underappreciated skill. And one of the areas where this comes into play is dealt with in a manuscript we have in press, and that's how one uses clopidogrel in patients with acute coronary syndromes. The specific questions that physicians have to deal with is knowing that clopidogrel is of benefit to patients with ACS, but that those patients who go on to surgery may have a detrimental effect in terms of bleeding. Number one, how should I use clopidogrel in ACS patients? And number two, how should this influence my decision about whether to operate and the timing of operation? And there are some data in this regard. We do have clear data that clopidogrel is beneficial to patients with ACS, and in fact, it's a Class 1 recommendation in the guidelines. We also know that about 10 to 15% of ACS patients will go off to surgery, to bypass surgery, and that those patients who receive clopidogrel within 5 days probably have some increased risk of bleeding and reoperation. So the question comes down, if an ACS patient is admitted, and of course I'm not sure whether they will be in that group that goes off to surgery, should I give the drug early on? And if I have, should I then always delay surgery? Now, to answer this question, there is a study by Dr. Berger et al. That's in press where they did a multi-center analysis of approximately 600 patients going to bypass surgery. Let me take that back. They did a multi-center analysis of approximately 600 ACS patients who underwent coronary artery bypass surgery, and about half of them had received clopidogrel and the other half had not. And then they compared the outcome in these patients. Now, what they found was that those patients who had received clopidogrel within 5 days clearly had more reoperations, had more major bleeds, and had a longer length of stay. But interestingly enough, the differences were not huge. For instance, in terms of reoperation, the differences were 6% in the clopidogrel group versus 2% in the controls. In terms of bleeding, 35% versus 26%. And in terms of length of stay, about 1 additional day for the clopidogrel group. So that it was impressive that the majority of patients who received clopidogrel had neither reoperation nor bleeding, and that if surgery was really indicated, that it could be taken with a reasonable risk. So the other important bit of information that came from this study was that whatever incremental risk existed with clopidogrel was related to timing. And so day 5 was worse than day 4, was worse than day 3, and by the time one got to day 2 or 1, that in fact the risk had diminished significantly. So what can we conclude from this study? Well, I think physicians are often confronted with the decision of whether or not to use clopidogrel in the ACS patients, and if they have, whether or not to delay that surgery. I would say, all things being equal, clearly one should delay surgery for at least 5 days after the administration of clopidogrel if you can. Having said that, if the patient has indications for surgery, particularly for urgent surgery, I think that the best judgment of a physician can come into play and say that the risk is offset by the benefit. For the Genuine Article, this is Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.